Hi, my name is Luke Niforatos. I'm the Executive Vice President at SAMS from Purchase to Marijuana, as well as Foundation for Drug Policy Solutions, our affiliated entity. I want to thank the INCB and VNGOC for this opportunity for civil society to give input into this process. I'm going to share my screen. I have some slides to share with you. So our view is that policy should drive us toward a culture of prevention and a climate of recovery. Every human life has the innate value and ability to live a life free from drugs and certainly free from addiction. And we think this should be the core value that leads all policy responses to the synthetic drug crisis. Harm reduction is something we should understand historically started in a good place, started as a rise out of the AIDS epidemic to help with, injection drug users not get HIV. So it came from a good place as a public health-based response. But what is meant by harm reduction as it relates to drug policy, I think, is very critically important. And you're going to hear a lot of harm reduction, I'm sure, from other people who will be speaking to this panel. But unfortunately, what we've seen is what started from public health and from a good place has now been co-opted. Extreme harm reduction, what we're seeing is, look no further than Ethan Nadelman, the founder and former CEO of Drug Policy Alliance, one of the international leaders in the drug legalization movement, called AIDS actually a black blessing and looked at harm reduction as basically any step towards harm reduction would drive governments towards the legalization of the manufacture, marketing, and sale of drugs and synthetic drugs. So we have to be very careful when we're thinking about harm reduction and understand its history. There's a public health intervention such as naloxone, which makes sense, but moving us towards this idea of safe supply or injection sites or even the legalization and commercialization of drugs like what we've seen with marijuana and psychedelics is a step too far, and it does not deal with this crisis appropriately. I'm going to give you a couple of case studies. Oregon's the first case study. British Columbia is the next case study. In Oregon, here in America, in 2020, they voted at a ballot referendum to decriminalize the use of all drugs, fentanyl, heroin, meth. People would receive a $100 fine, which was not enforced for their use. And so essentially use was legalized in Oregon. The outcomes were pretty much catastrophic by any number that you look at. More than half of the deaths for Oregonians 15 to 34 during that time period of this Measure 110 were from drugs. Less than 1% of people received treatment as a part of this, but people received a lot of syringe exchange programs and naloxone. So harm reduction was there, but treatment was not, is really the point from that data point. 18% in America increase in overdoses, 75% increase in Oregon. So many more overdoses in Oregon after decriminalization. Violent crime, much higher increase in violent crime in Oregon, 17% than nationally after they decriminalized drugs. We polled, and everyone in Oregon wanted to repeal this measure, which is what ultimately happened. But look at our minority populations, Black and Hispanic, overwhelmingly, and they wanted to repeal this policy. They saw that it was a disaster for public health, public safety. People were not receiving treatment. It was nothing of what was promised. So in early 2024, this year, the Democratic-led legislature, so very progressive, very much wanting to prioritize treatment and harm reduction, they voted overwhelmingly, and the governor signed a repeal of Oregon's decriminalization policy. So this was a failed policy in Oregon. Now no state in America has decriminalization of drugs as a result of this failure. And so I think it's really important to point out that when we decriminalize and normalize the manufacture, use of synthetic drugs, horrible, horrible harms can take place at a population level, from public safety to public health. The supposed compassionate approach to drug use and addiction is actually not compassionate at all. People end up living on the streets in record numbers, which is what Oregon saw, hopelessly addicted to deadly drugs that just get deadlier as we normalize them. So speaking of getting deadlier, let's look at British Columbia. So in British Columbia, the province in Canada, they have the worst drug overdose death rates in North America, far worse than America, where, again, drugs are prohibited. They are not normalized. America does not have, is just now beginning to experiment in a couple of places, but for the large part, does not have injection sites or safe supply, quote unquote, supposedly, of drugs. British Columbia has chosen an extreme harm reduction approach, focusing on safer supply of drugs, focusing all their funding on injection site access, basically full harm reduction response, very little recovery, very little funding for prevention. And yet British Columbia has a far worse rate of overdose deaths, far worse than the United States of America does. And it's been so bad in British Columbia that they have now reversed a large portion of their drug decriminalization law. They received an exemption from the federal government to decriminalize drugs. They have now petitioned and been granted that petition to reverse course on that. So now, particularly public use is not decriminalized anymore because of the problems that we're seeing: parks, beaches, and public transit. They have safer supply in British Columbia, and this has done nothing to help with the opioid-related poisonings, which continue to increase there. And also what we've seen is 90% of safer supply. Again, this is what they call safer supply. It's not actually safer. Safer supply patients have diverted and resold their prescriptions of hydromorphone. So again, this is something that's resulted in the normalization of drug use. Another harm reduction intervention that we hear a lot about is drug checking programs, which possibly can be helpful as a part of a broader strategy to reduce use of drugs and deal with addiction and get people into recovery. But it's important to note that these programs suffer from inaccuracies. There are a lot of false positives and false negative results, thereby sending a very false sense of safety and security to a drug user who, somebody who's using drugs, who, they would think that it's safe because it doesn't have fentanyl, but it's actually not safe because no drug is safe. And it sends the wrong message about that, as well as just the deadliness of the drugs that are out there. So what we would like to see as a response is evidence-based prevention needs to be the primary focus. 95% of people who don't use by 21 they are very unlikely to ever use. Every $1 we spend in treatment as a society, we save $12 in costs. And law enforcement must continue to be a part of this equation. We cannot make it comfortable for people to be homeless and using drugs and addicted. They need help sometimes to get into treatment. So good drug policy looks at the total harm reduction, not just extreme harm reduction. So these solutions all need to happen together. And I want to thank you all very much for the opportunity to give input.